Yeah, happiness. I'm back here with the next topic, that is the internal anatomy and the considerations. Okay, so it is one of the important topic, and of course, I can tell you this is one of the memory-based topic in entire subject of endodontics. In a few cases, you may miss the logics, but it is mandatory that you have to learn because they are going to give questions on this particular area. So let's start the topic. So first of all, how can I compare? Like something like you are if you are adapted to a particular room. For example, you have your study room, and you're very adapted to your room because you were staying in the same room for years. So what happens is on one day there is no power, okay, but you can enter the room because you are well aware of the room, because you know which object or which article or which book is there at which place, and you can easily close your eyes and you can easily pick the book because you have command on the anatomy of the room. So endodontic anatomy is something like that. If you don't know, you cannot enter because it's something like a blind game until you have an endodontic microscope or until you have a dental operating microscope. If you have a dental operating microscope is going to improve the visualization, means it's going to provide you the magnification, and it's going to provide you the illumination. It's going to provide the light for the dark room. Whereas regular, most of the operated systems, like we go for blindfold. We don't know what is there, but we just dig and we just find something. So it's something like that. A successful root canal treatment requires a strong command knowledge on the anatomy of the teeth as well as the anatomy of the root canals and their modifications. So there are few things which I'm going to discuss. Basically, I'll be focusing more on your questions rather than the concepts. So because I'll try to cover the areas where most of your questions will come from. So as already discussed, okay, so when you want to visualize something, like when you want to visualize the dentinal maps which are on the floor of the pulp, or if you want to visualize the fractures or crack tooth syndrome, I told you to use a dye, that is preferably you can use this methyl blue, or you can use 2% of iodine, okay, followed by you're going to visualize under dental operating microscope or under magnification, either by using loops, so that you can visualize this dentinal map clearly. And just to make a note of this particular test, which is very very important, they're going to ask the questions that is called as Samphase bubble test. So regularly, what is the mechanism of sodium hypochlorite? Of course, we'll learn it in irrigation solutions. The mechanism of sodium hypochlorite is to identify the vital structure, is identify the organic structure and dissolve it. So while dissolving this organic structure, so the leftover vital structure, means the vital structure in the root canal is going to be the vital pulp. We can see this vital pulp. So whenever it identifies the vital pulp, it is going to dissolve. So when dissolving, it's going to release bubbles. That bubble test is called as Samphase bubble test. The material used is sodium hypochlorite, and it's going to identify the mist canals where the vital pulp is there. The next one, of course, radiographs remains the primary and the most important method of identifying the root canal morphology. But is it one radiograph? No, it is a radiograph of multiple directions. So there is one question that is given in one of the recent session, like what is Walton's radiographic method? So Walton's radiographic method is something very specific to endo. Okay, so you take two radiographs with a difference in horizontal angulation of 10 to 15 degrees. So you maintain the same vertical angulation, but you will have a different horizontal angulation. So the change in the horizontal angulation is, what is the change? The change is 10 to 15 degrees. So when you change this horizontal angulation by 10 to 15 degrees, you can see the overlapped things. For example, in one situation, there may be two canals which are present on the distal root of the mandibular molar may overlap. But once you change the angulation, they can be seen as two. That is the main use of this Walton's radiographic method. So make a note, always try to take more than two radiographs. More than two radiographs are mandatory, and different horizontal angulations maintaining the same vertical angulation. Same vertical and different horizontal. Very important. The next comes, of course, the latest trend of CBCT has lots of importance in dentistry, and of course I like most of you are preparing for DDS, and according to my references and according to my like feedbacks from my seniors and most of us in USA, it is mandatory to take a radiograph before you start any root canal treatment, and they charge a decent amount for CBCT also. But I feel like in India, it's very rare to see a CBCT before you start an endodontic treatment in the clinical scenario. Very, very rare in the clinical practice. Like in the colleges for the academic use, of course, I have taken CBCTs, but so that's what the trend is like in USA. So it is mandated that you have to learn so much related to CBCT. So CBCT is something like it's going to give you three-dimensional view. It's going to give the anatomy at different levels, anatomy everywhere. So it is the best modality. It's a non-invasive best modality by which you can, know the anatomy without damaging the tooth structure. Right. So you can see this is a case where you can see more canals. Regular anatomy, as everyone can do, but a tricky or complicated anatomy, you must need aids like CBCT. You must need aids like dental operating microscopes to see that with the naked eye, because it's all like blind game. Until now, everything is blind game. So you need something to visualize it. So the best method is going to be the CBCT. And of course, I already was stressing you from day one that is dental operating microscope. Make a note, there are few dental colleges, like dental schools and dental universities, which may ask you to do your bench test under magnification, either by using the loops or either by using the dental operating microscope. Like before you go and attend this bench test, make sure you just aware of this. Okay, so because most of you were not well aware of dental operating microscope, so you need to work, or loops. We regularly don't use it. Okay, so I want you guys to make a note of this. Okay, in future it is required to know what is happening around this. So I just want to talk about few important aspects here and there, which were given in examinations, or which were the questions in your examination. So first I'm going to talk about the maxillary central. Regularly your maxillary central incisor is going to have one root and one canal. You can see the lateral canals in 60% of cases, and your maxillary central is most often, if you see the canal, it is most often triangular in shape. Very rarely you can see oval. So it's better to go for a triangle as a very, very decent and a good option. The next comes is the maxillary lateral. So maxillary lateral, you will have curvatures. Curvatures are most common in maxillary lateral incisor. Okay, regularly you see one root and one canal, and the shape, if you come to the shape, it is oval in shape. You will have curved roots. Make a note, you'll have curved roots, and make a note, we have already discussed these 2 points, that is your palato-gingival groove is most common at this area, and your palatal abscesses. Your palatal abscesses are also most common in the maxillary lateral. The next comes is the maxillary canine. Maxillary canine is also one root and one canal mostly, and it is the longest. Okay, your maxillary canine and mandibular canine are the longest tooths in the oral cavities. Okay, and if you see the cross section is oval. And make a note, your maxillary canine is having a digital inclination. Okay, so all your maxillary lateral, maxillary central, maxillary canine, all these are having a bit distal inclination. Okay, so that's an important thing that you have to make a note. So I'll straight away jump to the mandibulars. Okay, so coming to the mandibular centrals and laterals, mostly it is centrals and laterals are they contains one root, but chances of two canals are common, right? Chances of two canals are very common, like in 20 to 40% of cases you'll have two canals in the maxillary central and lateral incisor, and the cross section you see is long oval. The cross section you see is long oval in this case. And coming to the mandibular canine, so the few important things that you have to make a note about mandibular canine: one root. Okay, one root, you'll have one root, and the crown was labially inclined. You'll have a labial inclination of the crown. So whenever you have a labially inclined crown, make sure you try to do the access opening by giving the proper direction. If not, you're going to cause the perforation, right? So it is very, very important. You just make a note about this labial, labially inclined. Okay. And the next important aspect is coming to the cross section, is it is large oval. Okay, so these are the important things that you have to make a note. And of course, these she-shaped canals are not much familiar in the case of Americans. So they may not ask you questions, because these are most commonly seen in the case of Asian people. Okay, they may ask this question in the bench test. Okay, so she-shaped canals are most commonly seen in which of the teeth? The she-shaped canals are most commonly seen in the case of mandibular second molar. Mandibular second molar, you can see the she-shaped canals most commonly, and these are common in the case of Asians. Okay, hope you have done these important points. And coming to this normal tooth structures divided into coronal, root, and radicular portion, and each component is going to have enamel, dentin, pulp, cementum, and PDL, which we are going to discuss in detail in dental note. So the pulp is classified into coronal pulp and the radicular pulp. And the coronal pulp, of course, this is a question again for you guys. Coronal pulp has how many surfaces? Coronal pulp has 6 surfaces. What are the 6 surfaces? That is occlusal, mesial distal, buccal lingual, and floor. Make a note of this. Next, jumping to the pulp horns, and of course, I hope you know the meaning of pulp horns, which are going into the cusps and the lobes. And then application-based question is, why permanent crowns are contraindicated in young individuals? Because pulp horns are highly placed. When you're giving crown cutting, there are high chances that the pulp horns can be exposed, right? The next course is the radicular pulp. Radicular pulp is the pulp that extending from the cervical region of the crown towards the apex. So this part is called as the radicular pulp. So the radicular pulp at the end is going to communicate with the periapical connective tissue through a foramen called as the apical foramen. The next comes, you need to make a note of this landmarks. That is, the most important essential landmark to identify the pulp chamber is cemento enamel junction. So make a note, cemento enamel junction is an important landmark for location of pulp chamber and orifices, whereas cemento dentinal junction is an important landmark where your root canal preparation should end. Okay, so if you see this dental structure teeth, okay, so this is your cemento enamel junction, whereas this is your cemento dentinal junction. So your root canal preparation is going to start at cemento enamel junction and end at cemento dentinal junction. So this is the end where you are going to find the working length. So your working length, your biomechanical preparation, your obturation, everything should end at cemento dentinal junction. They should start at cemento enamel junction, right? So location of pulp chamber, cemento enamel junction, and end of your preparation, everything, cemento dentinal junction. So these are the few laws that you have to make a note. Law of centricity means your floor of pulp chamber is always located in the center of the teeth at the level of cement enamel junction. Law of concentricity says that the walls of the pulp chamber are always concentric to the external surface, okay, same as external surface at the level of cement enamel junction. Law of CEG is, of course, this is a constant and important landmark which helps in the position of the pulp chamber. Okay, the next goes is basing upon the relationship of the pulp chamber and the clinical crown. The pulp horns, the pulp chamber has some symmetric laws. The symmetric law is symmetric law 1. The law 1 says that except, there is exception, except for maxillary molars, the orifices of the canals are equidistant. Means they are, if you draw like this, they are equidistant in a particular direction, that is the mesodistal direction. Law 2 says that except for the maxillary molars, the orifice of the canals lies a line perpendicular to the line drawn from. Okay, this is a line. Okay, if you draw a perpendicular line, they lie in the same area. So if you draw a perpendicular line, okay, across the center of the pulp chamber, so this is law 1 and this is law 2 of symmetry. Law of color change, as already discussing about the dentinal map. So the dark color where you can see something like a map, this is called as dentinal map. So the color of the pulp chamber is always darker. So the dentinal map is always darker than the walls. The walls will be bright in color, whereas your dentinal map will be dark in color. So law of orifice location 1. The orifice location 1 law says that most of your canals are located at the junction of the wall and the floor. So this is the floor and this is the wall. So at the junction of both, so at the junction of wall and floor, you can see your orifices. Location 2 says that it is located at the angles in the floor and wall. Previously I told it can be located in the junction. Junction is this, angle is this. So if it is not located in the junction, it will be located in the angle. Next, orifice location 3 says that, okay, previously the first one is junction, the second one is the angle, and the third one says that it is located at the terminals of the root developmental fission lines. Okay, so root developmental fission lines are nothing but the same area. Okay, developmental fission lines is a place where you can see the orifices, is the law of orifice location 3 says that. So we need to make a note about the canal configurations. According to the Wiens, there are 4 types of canals. First one is 1-1, means it starts as a 1 and ends as a 1. Second one is 2-1. Okay, it starts as 2 separate canals and ends at 1, so it is called as 2-1. The third one is 2-2, starts at 2, 1-2, ends at 2, 1-2. The fourth one is starts at 1 and ends at 2. So it is 1-1, 2-1, 2-2, 1-2. That is type 1, type 2, type 3 and type 4. So there is slight modification of Wiens and it is done by vertices. In vertices you will have 8 types. Okay, that is type 1, that is 1-1, type 2, that is 2-1, type 3, 1-1, means it starts as 1, splits into 2 and ends at 1. Type 4, which is 2-2, starts at 1-2, ends at 1-2. You have, this is 2-2. The next comes is type 5. Okay, type 5 is starts at 1 and ends at 2. Type 6, it is starts at 2, combined to 1 and ends at 2. Type 7 is 1-2-1-2, starts at 1, splits into 2, again 1 and split into 2. Type 8 is 3-3. You have 1-2-3, you have 1-2-3. I hope it's very, very clear. They're going to ask this configuration. Questions were being asked, so please do make a note of this. The next comes are the accessory canals. So accessory canals are an extra canals, right? It's an extra canals. You can see all these minute extra canals. So these are the minute canals that are extended horizontally or vertically, laterally from the pulp and periodontium. Okay, so these are either horizontal, vertical, lateral, and make a note that 98% of apical ramifications, 93% of lateral ramifications are present in apical 1/3. So this is an apical 1/3 area where you see lots of ramifications. That's apical is 98 and lateral is 97. So that is the reason why whenever your root canal system fails, we generally go for apexectomy. So apexectomy is done by, like, how many millimeters it is done by? So it is done by 3 millimeters. Why? Because all these apical and lateral ramifications are present in the 3 millimeters. So remove them, because these Ramifications are the primary reason for the endodontic failure. So remove them. Your accessory canals, your lateral canals, all these ramifications are the causes for the failure of endodontic treatment. So remove them. So, okay, if you want to remove, where you have to remove? So this apical 3 millimeters is going to contain them, so remove it, right? So basically, how these apical accessory canals are formed? Accessory canals are formed by the entrapment of the periodontal ligament vessels in this root epithelium during the calcification, because of which you can see this accessory canals. And detection of accessory canals. How can you detect an accessory canal? So when you're going through the periodontal ligament during your radiographic observation, if you see a periodontal ligament, observe the thickness of the periodontal ligament or the periodontal ligament space. Suddenly you can see a bubble, or suddenly you can see some deviation on the lateral wall of the root. Okay, because if you see, this is your periodontal ligament. So suddenly if you see some morphological change in the periodontal ligament, for example, this is your root, and you see your periodontal ligament like this, suddenly you can see some extra thing. Then you can predict, okay, there is some chances of occurrence of some accessory or lateral canals over that particular area. Significance is they play a very vital role in the exchange of the irritants or the bacterial components, okay, because they are going to be the culprits for the endodontic failure. And pulp may be in this area may be inflamed or necrotic. Okay, so you need to take certain precautions to remove this and to make this area very clean. Okay, because it's very difficult to access with a normal conventional endodontic therapy. So you need to go for advanced endodontic therapies where you need to plan and remove these accessory canals. So the next goes is the fercation canal. Canal which is seen in the fercation area is called as fercation canals. Okay, so these are most commonly seen in the case of multiple rooted teeth, where you'll have bifurcations, trifurcations. At that particular area, you can see these fercation canals. Isthmus. Okay, I hope you have learned this definition. Isthmus is a two canals, okay, when they're connected by something which is not visible. So isthmus is defined as a, you can see the diagram as a ribbon shaped intercanal communication or a transverse anastomosis or a corridor between two root canals where you can contain dental pulp and pulp related tissues. So that is called as isthmus, and you have to take utmost care to dissolve or remove the pulpal tissue or the irritants that are present in this isthmus area also. It's very difficult to do this, but by using the advanced irrigation solutions or irrigation protocols and the devices, you can remove the isthmus also. So we'll learn about few abnormalities. Okay, this is an abnormality which is seen in the Asian population, but it is very familiar, so they can ask you. Okay, shovel-shaped incisors are seen in the case of anterior teeth. Okay, the next comes is, of course, we have discussed this in the class. That is this palatogingival groove surgery I have discussed with you. So this is lateral incisor which is having this palatogingival groove which is leading to endoperial lesion. So how you have to treat? You have to open the flap and you have to seal everything over this particular area with GIC, followed by, because you have a heavy bone loss here, so it is mandatory that you have to keep a bone graft over this particular area and you have to seal it. So suturing is done. So this is a 3 months follow-up and this is a 6 months follow-up. You can see a reduction in the radiolucency. Okay, so here compared to here, you can reduction in the radiolucency and decreasing in the probing depth. Okay, so let's learn a few important aspects. Your maxillary and mandibular molars are very, very important, because I can see many questions on this particular area. So we'll be discussing the mandibular molars in detail. So coming to the mandibular molar, that is the first mandibular molar. You can see the outline. The outline is trapezoidal in outline, important point. And if you see the canals on the mesial side, you have two canals. Distal side, in the most of the situation, you have one canal. So these two canals are the mesolingual and mesobuccal. One is going to the lingual side, one is going to the buccal side. And the distal canal is regularly oval in shape, and you have one distal canal which is largest in most of the cases. Okay, and if it is the largest one, and if it is one, it is regularly present in the central. But if you suspect a canal which is present in either buccal or lingual direction, not in the central, then you can assume that there are two canals. Okay, for example, if you find it on the buccal side, there is still canal, then you have to negotiate and try to find on the lingual side also. Then if you have two canals on the distal side, that can be seen in 28% of cases, these two canals are nothing but distolingual and distobuccal. So if it is three canals, that is mesolingual, mesobuccal and distal. If it is four canals, that is mesolingual, mesobuccal, distolingual and distobuccal, right? So this is an important thing that you have to make a note. And make a note, your axis opening should be always on the mesial side. Okay, 2/3 of your axis opening should be on the mesial side, because your pulp chamber, the 2/3 of the pulp chamber of this teeth will be on the mesial side. So your axis opening should begin on the mesial side. Okay, so that is very, very important that you have to make a note. And the teeth which most frequently go for endodontic treatment, mostly endodontic treatment, is your maxillary molars. Sorry, your mandibular molars when compared with the maxillary molars. Okay, so morely we do endodontic treatment on the mandibular molars, because mandibular molars are more prone for dental caries. Because in most of the situations, molars leading to pulpal infection is because of dental caries. So dental caries is more in the maxillary, is more in the mandibular first molars. Okay, it's more in the mandibular molars. So root canal treatments are more in mandibular molars when compared with the maxillary molars. And make a note, care should be taken because these mandibular molars are more prone for lingual perforation. So you do more lingual perforations in this mandibular molars, so you have to take utmost care to avoid that. Okay, so that is an important thing that you have to make a note. So this is the difference between the maxillary and the mandibular. Okay, so you can see this is a maxillary molar. Regularly you will see this is a palatal. Regular. This is a maxillary first molar. So this is a palatal one. Palatal one is the biggest one, and the next one is you'll have mesobuccal and you'll have distobuccal, right? So this mesobuccal is, one is MB1 and one is MB2. So mesobuccals, sometimes it will be one, and most of the cases it will be splitted into two, that is mesobuccal and 1 and mesobuccal 2 and distobuccal, and this is a palatal. And coming to the mandibular, as already discussed, regularly you'll have your mesobuccal, okay, your mesolingual, distobuccal and distolingual. Regularly you may have this configuration. Two, sometimes the 3 canals may be split into 4. Your maxillary molar will have this combination 3. If it is 4, it will be split into 2, that is MB1 and MB2. I hope you're clear about this. So when I'm talking about this, I was already done with the mandibular first molar. Now I'll be talking about the maxillary first molar, because most of your questions will move around the maxillary and mandibular molars. Okay, so the first important thing is the triangular outline. The outline of the chamber is triangular outline, and if you see this, what we have discussed, the triangular outline is this is one, right? This is one, right? And this is one, right? This is MB, this is distobuccal, and this is palatal. So this gives a triangular shape, right? This triangular shape. So in this triangular shape, the apex is formed by the palatal. Okay, the apex is formed by the palatal root, whereas your base is formed by these two. Okay, your base is formed by these two. And whenever you have the suspection of the fourth canal will be lingual to that of the mesobuccal. So your MB2 will be lingual to MB1. Okay, lingual to the MB1. Okay, the next important thing is most common cause for the failure. Okay, teeth with maximum failure rate is the maxillary first molar, because most of us with the naked eye, it's very difficult to identify this MB2. So that is the reason why. So the most complicated root canal anatomy or the most complex root canal anatomy is seen in the case of maxillary first molar. And you can see 90% of cases of maxillary first molar will have this MB2 followed by your accessory canals. And more than 58 to 60% of cases you can see MB2. So MB2 is seen in more than half of the cases. Okay, and make a note, your palatal canal is the largest canal and it is the widest canal. It is the good tapered canal, very well good tapered canal you can see in maxillary first molar. So apart from this, when you want to place post, there is something called as post and core, which we'll be discussing further. So when you want to place this post, okay, for a particular teeth, post should always be placed in the largest canal. So for a maxillary first molar, the post should be placed in the palatal. For mandibular first molar, the post should be placed in the distal. Okay, so these are the important things that you have to make a note when I'm talking about the maxillary first molar. The next comes is I just want to give a brief idea about this maxillary first premolar. Few questions on maxillary. Few questions on your maxillary first premolar. So coming to the maxillary first premolar, regularly your maxillary first premolar will have two canals. So your maxillary first premolar will have two canals. In most of the cases it will be two canals, right? So and like in around like 70% of cases it will be two canals. In around like 30% of cases it will be one canal. Okay, one canal. Okay, so this is I mean like this is 2 that is 2 means two configuration, two roots and two canals in the case of 70% of cases, and one root in case of 30% of cases. This is regularly. And out of these two canals, if you see the two canals, one is buccal and second one is palatal. The palatal canal is the largest and the wider one. Okay, the palatal canal is the largest and the wider one. And make a note, maxillary first premolar, there is one problem on the mesial side, that is you can see this mesial concavity, which we'll learn in dental anatomy. So this mesial concavity is the most common site of perforation. So you have to be utmost care when you're treating the maxillary first molar endodontically, because there are high chances that you may perforate at this area. So when you come to the cervical level of this maxillary first premolar, the cervical level where you can see an elliptical shape, and few people they call it as a figure of 8. They call it as figure of 8. But make a note, the opening axis opening of this maxillary first premolar is the oval shaped. The next goes is the maxillary second premolar. So we are done with the first until now. So we'll be focusing on the second premolar. So maxillary second premolar is almost like the same. It has 75% of single root and around like 20-25% of two roots. Very rarely you can see the other modifications in this. But make a note, the difference between the max first and mandibular first is mandibular second premolar is mandibular second premolar has high incidence of accessory canals. Around 60% of cases you can see these accessory canals. And make a note, all the maxillary teeth are in very close approximation to that of the maxillary sinusitis. So you have to take utmost care regarding the maxillary sinusitis, okay, when you're treating this maxillary teeth, that is the maxillary first second premolars, the maxillary first and second molars. Okay, so this is all about your maxillary second premolar. The next comes that we need to make a note about the mandibular premolars. So the most commonly asked question about mandibular premolars is, if you consider these two, I'm not good at diagrams. If you consider these two as a mandibular premolars, so make a note, there is some landmark that is present between the two premolars. That landmark is called as a mental foramen. So you have to use slob rule to rule out. So whenever you are planning endodontic treatment in relation to these teeth, and sometimes what happens, like if you do slob from this side, what happens is the same IOPA can look like this. So this is an overlapping. This is actually not a periapical lesion. This is in a mental foramen. Sometimes it can be periapical lesion also. So what you have to do is, like, you have to apply the slob rule so that by changing the angulation, the mental foramen changes. Like if it is moving away, then it is mental foramen. If it is like in the similar way, something like this, after changing the angulation, if it is something like this, so then you can consider it as a periapical lesion. So it is very important consideration. You can apply your Waltron's technique over here, or you can apply your slope technique over here to identify whether it is a mental foramen or whether it's a periapical lesion. And second most important thing, as you have a bundle of nerves which are going in between these teeth, okay, regularly your periapical endodontic surgeries. So something like we have an endodontic surgery topic also. These surgeries are contraindicated in this particular area because you have a vital structure, that is a mental foramen containing the mental nerves is there. So the endodontic surgeries are contraindicated in this particular case. And the next important thing that you have to make a note is your mandibular first and second premolars. So the difference between the first and second premolars when coming to the anatomy is, the first premolar will contain two canals which may end with two orifices or which may end with one orifice. Okay, so this is around like 27% of cases. And the second one is, mostly it will be 1 and 1, that is one canal and one foramen, and it will be around like 80 to 85% of cases. So that is the basic difference that you have to make a note when you're talking about the first and the second premolars. Okay, so I think this is more than sufficient. So last but not the least is, you can see this typical morphologies which are nowadays the most commonly asked question. That is, one is entomolaris and second one is paramolaris. So what is entomolaris? Entomolaris is an additional distolingual root. Okay, both are seen in the mandibular molars. Okay, so if it is an additional distolingual root, then it is called as entomolaris. If it is an additional distobuccal root, then it is called as paramolaris. Okay, so make a note, ento is distolingual root and para is distobuccal root. Right, so please do make a note of these two differences, because again these two are commonly asked questions. If you see the recent sessions of your Inbde as well as Nbde part 2, there were lots of questions moving around this in many official groups. Okay, done for now. Signing off, Dr. Srikanth from team Inbde CONQUER. Let's enjoy this learning phase, which not only gives you the tagline of pass in the examination, but gives you lots of knowledge and interest towards dentistry or a particular field in dentistry. Love.